ఒక డాక్టర్ విളിക്കണം డాక్టర్ విളിക്കണം
Good evening, everyone. Respected Dr. Shibu Sridhar, distinguished members of IADP, and dear doctors. A warm welcome to each one of you to another enriching session of our Learn from Master series organized by IADPE. Crossing 100 webinars is definitely an amazing ride so far, and I thank all the doctors who have been a part of this journey. One of you to another enriching session of our Learn from Master series organized by IADPE. Crossing 100 webinars. It gives us immense pleasure to have all of you joining us today. Your enthusiasm for continuous learning is what inspires us to bring together some of the finest clinicians and educators in dentistry. For those joining us for the first time, IADPE is an educational platform committed to promoting excellence in dentistry. We strongly believe that quality education and continuous learning lead to predictable clinical outcomes. Through our workshops, webinars, and hands-on training programs, we strive to bridge the gap between theoretical knowledge and clinical excellence. Today's webinar is especially exciting as we explore one of the most important aspects of modern aesthetic dentistry, an introduction to direct composite and porcelain veneers. It is my great honor to introduce our esteemed speaker for today's session, Dr. Shibu Sridhar. Dr. Shibu Sridhar is a highly respected endodontist and restorative dentist with over 18 years of clinical experience in restorative dentistry, endodontics, and general dentistry. He completed his BDS in 2004 from A.B. Shetty Memorial Institute of Dental Science, Mangalore, followed by his MDS in conservative dentistry and endodontics from Padma Shri Dr. D.Y. Patel Dental College in 2008. After serving as a senior lecturer at Indira Gandhi Dental College, Kodamangalam, Dr. Shibu dedicated himself entirely to private practice, where he developed a special interest in microendodontics, surgical and non-surgical endodontic retreatments, management of complex endodontic cases, and biomimetic restorative dentistry. He is the founder of Outlook Center for Advanced Dentistry, Kochi, where he focuses on advanced clinical practice and conducting comprehensive training programs for dental professionals. Adding to his impressive credentials, Dr. Shibu has completed the Continuous Professional Development Program from FGDP UK and holds a mastership in biomimetic dentistry from the Element Center USA. He currently serves as a faculty member for GC, is an international faculty at Rosario University, Argentina, and has delivered numerous lectures across India and internationally, inspiring thousands of dentists with his excellent based approach and clinical excellence. We are truly privileged to have him with us today. Without taking much of your valuable time, I request Dr. Shibu Sridhar sir to kindly take over the session. Over to you, sir. Welcome.
Thank you, Dr. Juna, for the fabulous introduction. Good evening, my dear friends. Today, we are here to discuss about the recent developments which has happened in the field of restorative dentistry. So we would be dealing with both direct restorations as well as indirect restorations. Fine. So traditionally, we had divided our restorations into directs as well as indirect restorations, which you all are aware. But it's like now we have direct restorations, semi-direct restorations, semi-indirect restorations, and indirect restorations. All these things we would be briefing through in this 1.5 or 2 hours today. So First of all, I'm sorry that I am a bit tired. I'm sitting here after a full day training session. I'm at, it's like we had a pre-conference session for the Sri Lankan Dental Association conference, which is happening in Colombo. So right now I am joining you from Colombo. Now, yep. So let me start with a very interesting case. This was one of an eye-opener case for me, something which was a milestone in my career. So here, the first picture on the top, you can see a root canal treatment was done. And as usually what happens, it is like once the pain vanished, the patient too vanished. And after a few months, he came back to our office. He complained that he is having a pain on the tooth, which we had done a root canal treatment a few months back. On an IOPA, it is evident that it is a suspected vertical fracture. And the second picture, you can see that the tooth was extracted. It was stuck back, re-implanted in the socket, which was followed up for 2 years. Later, that was taken as an abatement and a bridge was given. The bridge is there for the last 12 years. So this was something which changed my perspective about adhesive dentistry. Now I'm convinced that adhesion is something which can last really, really long when done correctly. Fine. So another issue which we usually face in routine clinical dentistry would be the fear to do a composite restoration, wherein the caries is gone very near to the pulp. So here you can see that the caries has gone really near to the pulp. And in such cases, we are afraid of a situation wherein the tooth can turn non-vital. That was one of the biggest issues which we were facing with composite restorations. So it's like we have now a lot of articles which says that the bonding agents protect the pulp. So I too read them, but still I was doubtful as a clinician. I was doubtful about how this can happen. Because all through our graduation as well as post-graduation, we were taught that composites irritate the pulp. And how can one fine day it so happen that the bonding agents are protecting the pulp? Anyway, the bonding agent was lying there in my cupboard for a long time, and I never got a chance to try that out. Because see, you never, it's like if something is working for you and you don't have to change it, right? So I didn't want to change my protocols, and this went on for a while wherein I was not believing in this. So then this was a very loyal patient of mine. I'm seeing this person from the very beginning of my practice. So this was a case wherein we had considered a root canal treatment here. So I just thought of excavating the caries. You can see the rubber dam isolation, and you can see a class 3 on the mesial side as well as distal side, which is continuous with a class 5 as well. So this is the caries excavation. I thought of going ahead with a pre-endodontic buildup. Anyway, I'm going to do a root canal treatment here. And you can see I have exposed the pulp from the mesial side as well as the distal side. So went ahead with immediate dentin sealing and a composite restoration. And you can see the restoration was done in 2018 and the follow-up in 2024. So as a 6-year follow-up, the tooth is still vital and we have not done a root canal treatment. So another big issue, that is composites can irritate the pulp. Now it's like I'm convinced that it can protect the pulp too. So this case was shown for the purpose of conveying the thing to you, that is, in modern restorative dentistry, pulp protection is immediate dentin sealing. Fine. The bonding agents are going to protect the pulp, provided you're using the gold standard bonding agents. Fine. So we don't use any calcium hydroxide sub base to protect the pulp. This is done by the bonding agent itself. Now I'll share you another case. See, why I am showing this case is, see, what I focus on in my practice is restoration of badly mutilated teeth. So if you're following me on social media, you would see that most of my cases are on restoration of badly mutilated teeth. So here, I'm sure that you can find out the truth which has been restored. Now let's go back. Let's see how this was initially. So the patient had a fall and he fractured the central incisor. You can see that facially the fracture appears favorable, but it's an oblique fracture which is going down all the way to the midroot. And by all norms of dentistry, we would see that this has a hopeless prognosis, right? So you can see how we manage the case. So the fractured fragment was detached, flap was raised, the deep margin was acquired, and you can see the rubber dam isolation. In fact, the flap was kept opened, and then we went ahead with the rubber dam isolation. That's the isolation. And after a root canal treatment, the fractured fragment is attached. You can see that the fragment was fractured up to the middle third of the root. Fine. Now I am showing you a 3.5 years follow-up of this case. Still, the tooth is going strong. You can see the IUPS as well. In fact, you can see that the bone level has improved in the past few years. So again, what we have to understand is how we have classified the prognosis of the teeth in our conventional dentistry is something which is outdated. In modern dentistry, adhesion, the techniques of adhesion, the science of adhesion, our understanding on the adhesion has improved drastically, so that most of the cases which we were not able to manage in the past can be easily managed today. Fine. I'm not just talking like that. I'm showing you the follow-ups also. Fine. You can see yet another case, a root stump by always. You can see the facial view of it. And a bit of gingivectomy was done to expose the deep margins. Then we acquired the deep margin, elevated that with composite. That's after the dentin replacement or pre-endodontic buildup. A root canal treatment was done later. Then you can see the gingivectomy site. That's about the ribbon placement, and which was followed by treating the first molar. A root canal treatment was done there, and the tooth was the coronal restoration was a direct composite restoration. And later you can see the follow-up. The papilla has grown nicely. That's the isolation. Then we had a class 2 on the distal side of the first molar as well as the mesial side of the second molar, which was restored. And you can see the restoration was completed with an enamel replacement done in Emax. So that's the facial profile, that's the emergence profile. So gone are the days of porcelain core, crowns, all those things are things of historical importance. We don't do them anymore. And you can see how we managed the tooth beautifully. There's a pre and the post, and even the first molar is root canal treated and managed with a direct composite restoration. The second premolar is restored with an Emax overlay. Yet another case. Again, a root stump. You can see the facial as well as the palatal view here. That's the deep margin acquisition. And before that, you can see how we acquire the deep margins with the retraction cord. That's a heavy retraction cord which has gone in. And I would say you something that the biggest learning curve is to learn to pack the heavy retraction cord without a bleeding. That is something which is going to take the maximum time. Fine. Margins are elevated. And you would also notice that the isolation is completed here with a ligation, which is done with the E module, which we use in ortho. You can see the red ring around the tooth. And you can see the tooth preparation. So we do the tooth preparation with the dam on. That's a preparation for the enamel replacement. And this will show you how much more specific and accurate we have become with our restorative protocols. As rubber dam isolation and final replacement of the enamel done with, again, Emax here, which is bonded with heated composite. So that's the final result. So this is how restorative dentistry has changed. And this is what we have to focus on in the days to come. Gone are the days of treating a tooth with conventional procedures like a post and core, crown, etc. Now let's go to the anteriors. A bit of veneers we'll see now. So when we're designing a smile with veneers, the first thing that we need to know is what is a beautiful smile. So a pleasing smile can be defined as one that exposes the maxillary teeth completely, along with approximately 1 millimeter of the gingival tissue, as you see in the picture here. A gingival exposure of 2 to 3 millimeter is aesthetically pleasing, while an exposure of more than 4 millimeters is considered as a gummy smile. Now let's see this case. So whenever we start with a case, we have to simulate or we have to mock up the final outcome first, and then we would start with the actual clinical case. So this is the initial evaluation to see the midline shift and all those things. And you can see the mock-up. So here the mock-up is done with freehand composites. So we do the composite and we show it to the patient. This helps the, even we can have a good clinical evaluation of how the result would be, and even the patient can have a good evaluation of how it is going to look after the treatment. So it's a pre-operative and the appearance following the mock-up, which is done with freehand composites. As a tooth preparation for the veneers, and you can see the final veneers on. And you can see the papilla is nicely squeezed so as to get a very good emergence profile. That's the pre and the post. So this is how we transform smiles. So doing a veneer is not just it's not something which is very difficult. It's very easy. Anyone can do a veneer, but planning a case is very important. What makes the difference is how you do the planning.
Good evening. Good evening, sir.
Yes, good evening.
Hello.
Good evening. I'm hearing you.
Sir, I have a little question. Sir, what is bonding protocols you have used here for the veneers? Can you please
Why don't
explain, sir?
we would explain that. We would explain all these things. So let me speak first, and then it is like I'll give a time for all of you. I'll hear all your queries and I'll answer all your questions. Okay.
Oh, okay. Thank you, sir.
Okay. So again, you can see here something which we have to all focus on is to do the preparation under magnification. So this is the microscope view. This is how we do the tooth preparation. We are very gentle. And you can see the retraction cord on. and how we refine the veneer preparation. This is another case. You can see we have a discolored tooth here. So we're doing a smile design. You can see how we plan the tooth preparation. That's how we polish the preparation. That's the final tooth preparation there. So something which we have to understand is, unlike the gross dentistry which we were doing before, now dentistry has changed a lot. So what makes the difference is the small things which we pay attention to. So let me show you another case. This was a case which was mismanaged with direct composite veneers. You can see all the gaps there is no separation between the teeth. Everything, everywhere it's filled with composite. And I would always say we are able to manage these cases only because we are practicing in India. So wherein all sorts of dentistry exists, you can see the most fabulous dentistry as well as cases like these two. So we did a mock-up, transferred the mock-up, and then finally you can see how beautifully we have changed the smile. So everything lies in how we plan the case. How meticulous the planning goes on. That is what decides the final fate of the case. So I'll show you a very special case wherein there is a combination of direct as well as indirect techniques. So here you can see that the black triangle is very evident. There is a bit of recession. There is the old composites. The biggest problem or the biggest challenge in such cases is to get the papilla down to close the black triangles. And equally challenging was the lower anteriors. You can see black triangles everywhere. The first thing we do in such cases is a black triangle closure with a very special matrix called the black triangle closure matrix, which would squeeze the papilla and get it down. So this would help to avoid massive tooth preparations to squeeze the papilla. So when we do a composite technique to close the black triangles, it's like we can minimize the requirement of an extensive tooth preparation. So it's not always about how you prepare the tooth. So the first thing we do is additive. We add composites, we manage the black triangles. So you can see all the black triangles are nicely closed with composite. Now we do a minimally invasive tooth preparation and then we bond the veneers. That's the lowers. You would have seen how minimal the tooth preparation was. That is the upper anteriors. There you have the lower anteriors. And you can see there was a gap between the canine and the premolar. Even that too is managed very nicely. Here it's like we have done an Emax veneer till the canine and the premolars have a direct composite veneer on both the sides. So this is an example of a case wherein there is a good symbiosis between the direct composites as well as the indirect techniques to get the best result. Fine. So that is why I was telling you in the very beginning that the result depends on how well the planning goes on. So that's the maxillary, pre-op and post-operative, the mandible, pre and the post. That's a patient. I'll show you another case. You can see an inverted smile line here. So we have to get the centrals a bit longer so that the maxillary anteriors follows the concavity of the lower lip. So you plan it with a mock-up. So now we establish the incisor length, everything on the mock-up. The patient is happy with the mock-up. The preps and the final veneers. That's a transformation. So you can see the inverted smile line was corrected. And this was the picture which I used when I was talking about, when I was explaining what a pleasant smile is. You can see all the characteristics of a nice smile is there. Again, another interesting case. So here a multiple diastema closure was done with crowns. The patient was too unhappy about the result. The crowns were removed. We did a mock-up with freehand composites. So the anterior 4 prostheses are crowns. We replaced the old crowns with new crowns. These are the vertical crowns, we call them, and veneers on the canines. So initially the patient was too shy to smile. I'll give you a follow-up of how things changed. So after a while, she wanted to correct the lower anteriors also. That's the lower anteriors corrected. And I can show you this was one year follow-up. You can see how the confidence of the patient was boosted. The smile improved. The way she carried herself also improved, and that's how she is now. So we may be just doing a couple of veneers, but literally this is going to change the life of the patient. Again, coming back to composites. So here it's like this patient was continuously getting diastema closures done. So every 4 to 5 months, the composite chips off or gets dislodged, and he will drop by the next clinic and get a diastema closure done. So something we always miss out in diastema closure is, it's like we don't manage the emergence profile. Fine. So proximally, you can see this is the black triangle matrix, which is inserted into the gingival sulcus, wherein the papilla is squeezed nicely. And you can see how well the emergence profile has changed. So for diastemas, we never do a layering technique for composites. Just keep the matrix and injection mold, which is going to give you fabulous results in diastema closure. Another case wherein you can see there is a tilt of the centrals. So we always do a mock-up to evaluate the final outcome. And then you can see a zero prep. So the biggest advantage of injection molding with composites is there is absolutely no requirement for any tooth preparation. So we don't have to touch the tooth with a burr, just the matrices and injection molding over untouched tooth, and see how fabulous the result is. Another case of smile design with composite. So one central incisor is injection molded. Then on the lateral incisors, the injection molding was done with the Unica anterior matrix. This is yet another matrix system wherein we don't have to bother about the proximal contours. It's all the proximal as well as the cervical contours are managed by the matrix band. So in these techniques, the biggest advantage is the shape of the tooth, the contacts, contours, everything is managed by the matrices. Fine. So we don't have a chance of going wrong with the shape, size of, imagine when we're doing 2 central incisors, the size of both the centrals should be the same. So when we depend upon the matrices for the final size, shape, and contacts and contours, there is no chance of the clinician going wrong. So that's the final result. Another case of smile design with vertical veneers. This is another type of veneers called the vertical veneers. So a case of generalized diastema. So that's the mock-up. So we planned on porcelain veneers from lateral to lateral and composite veneers on the canine. The canines are a bit rotated. And you can see how we transformed the smile. You can see the fabulous emergence profile. You can see the beautiful papilla compression. There is absolutely good gingival health. The stippling is there. So this is how we manage smiles. Again, a bit of overriding central incisors. Veneers to correct them. Of course, this case can be easily done with aligners. But again, nowadays, most of your patients get married the next day. So we don't have any other option. Just go ahead and manage them. So it's a 1-year follow-up. You can see this is yet another case of vertical veneers. How beautifully the gingiva responds to vertical veneers. Vertical veneers are very, very, very good for maintaining the gingival health. Now the case here, you can see the central incisor. They have a bit of mamelons still present. The patient never wanted the teeth to appear as if they are treated. So the first thing the patient told me is nobody should complain that nobody should feel that I've done a treatment. So slightly protruding centrals. That's a prep there. And the final veneers. So exactly we have followed the shape of the preoperative situation. So you can see how well we have managed the excessive proclination of these two central incisors. So here there is excessive wear of the central incisors. So this is a case wherein we have to correct the occlusion first and then go ahead with designing the smiles. So here we are modifying the palatal inclined planes. The first thing we do is we give palatal veneers so as to get the mandibular guidances correct. So this is how we do the palatal veneers in composite. And then we do the facial veneers in composite. So those are 10 injection molded veneers, injection molded direct composite veneers after correcting the guidances by modifying the palatal inclined planes. So only when the occlusion is corrected, the veneers are going to last. So you can see the guidances are re-established. You can see the excursions here. You have proper disocclusion of the posteriors. The group function is relieved after the treatment. This is yet another case of fluorosis. That's after the gingival retraction, isolation, and see the technique of removing the aprismatic or fluorotic enamel. So we don't use any burr, just the air abrasion system, and you can see how beautifully we are removing just the chalky enamel. Rest of the things are intact. We don't remove any of the hard enamel or dentin from the tooth. Just the chalkiness is removed. That's how things have changed now. That's the Unica anterior matrices. You can see the final. direct composite veneers. Yet another case, you can see uneven length of the centrals. Crowns were given. One crown was lost and it was replaced with a composite. So this is how we have to replan. So gingivectomy was done. Temporaries were given to re-engineer the shape of the gingiva. And see the finals. How well we have corrected the gingival zeniths, the emergence profile, everything. And also see the texture of the enamel here. So it's the pre and the post. So here we had a patient with a very masculine smile. So the requirement of the patient is the smile should appear feminine. So just went ahead with closing the diastema and veneers on the premolars. See how we could transform the case. So this is what I was saying. Everything depends on how we plan the case. We didn't do any preparation. It's all prepless composite veneers. So diastema closure with veneers on the premolars. So how the appearance is changed. You can just see the pictures. So again, yet another difficult case would be a single tooth veneer. Here we had to replace the composite restoration on the right central. The veneer prep is done. And you can see the technician has fabricated a veneer which looks exactly the same as the adjacent one. So another big issue in routine dentistry is the black triangles. So this is a post-orthodontic case, and you can see the black triangles. The contacts are intact, but you can see the gums have receded, and there is all black triangles present. And there is a bit of relapse and a diastema between the lateral incisor and the canine. And this is how we manage that with the black triangle matrices and injection molding. See how beautifully the black triangles are closed. There is absolutely no inflammation of the gingiva, zero preparation on the tooth. It's another case wherein a lot of old composite restorations were there. We did a mock-up transfer. That's a freehand composite mock-up. Patient was happy with the mock-up. So after removing the old composite restoration, I literally fell in trouble. It was all secondary caries underneath. All restorations were done, and then new veneers were given. You can see the result, the pre and the post. That's another case wherein it was gummy smile. You can see the enormous gummy smile. Gingivectomy was done, and then we designed the smile with porcelain veneers. So I'll show you a very interesting case. So you can see a huge crown given. Fine. So the patient, this tooth was root canal treated. And later, the patient developed a severe pain on the root canal treated tooth. So what happens usually is, when we remove the crown, there was tremendous leakage inside. The leakage has led to failure of the root canal treatment. So the root canal treatment was repeated. This procedure is called the immediate dentin sealing. You can see the ribbon placement. That's the tooth preparation for the overlay. And the final bonded Emax overlay. So the biggest problem with crowns is we always have gaps inside which lead to micro leakage. And one of the main advantages of adhesion-oriented restorations is the micro leakage can be drastically reduced if done properly. Yet another case is the cracks. So you can see the crack. The patient complains of pain on biting. You can see the crack. It's going all the way down into the distal roots. The root canal treatment was done, and this procedure is called crack dissection. Under very high magnification, we take a round burr and drill through the crack till the crack disappears. So all these procedures we were never familiar to these procedures in our conventional dentistry, and we are never taught these procedures in dental schools also. So these are the changes which has happened in restorative dentistry, and these are the newer things which is developed in dentistry. Another big issue of routine dentistry is the post and core. And most of the time you see that you take a lot of struggle in restoring a tooth with a post core buildup again, crown preparation, then the crown, and finally you would see the patient coming with the post and core with the crown in the hand. So it's a similar situation here. A crown is given. So that's a tooth wherein it's a case of an open apex. Apexification was done and a post was given and a crown was given. Later, everything went in for a failure. So we had to retrieve the post and do a root canal treatment. And after removing the crown, everything went off from my hand. It's like it was tremendous leakage inside and there is no coronal structure left after removing the crown. So this is, you can see the follow-up after 3 months. The lesion has healed nicely. The root canal treatment was repeated and a direct composite restoration was given. It's a 5-year follow-up. The structure was built up with composites. So gone are the days we don't require crowns anymore.
class चालू
That's another case wherein here the patient was complaining of a pain when he was biting. So that is something which is suggestive of a crack present inside. And you can see the crack. You can see the crack which was dissected off. The crack was removed. And then an indirect composite restoration was done. That sorted out the issue. No need of a root canal treatment in such cases. So this is usually one small request. Please mute yourself. So this is the restorative cycle. Normally, someone comes to you with a very small filling. After some time, you have secondary decay. Then it lands in a bigger filling. Later, there is again further damage. Then you move ahead with a crown, maybe sometimes, or sometimes you go to an endo and then the crown. And later, after some time, we see a fracture of the entire thing, entire tooth. Then you extract it and give an implant. So this is called the restorative death cycle. So the best way to avoid all these happenings would be to shift to the biomimetic dentistry. wherein the only form of dentistry wherein the lost strength of the tooth can be regained. The only way is with biomimetic dentistry. In no other forms of restorative dentistry, a tooth can be strengthened with a restoration. No, no way it is possible. And if you ask me, I would say that there are enough and more studies which have shown that a decayed tooth is always stronger than a filled tooth. So whenever treating the tooth, the first thing that has to change is the conventional tooth preparation techniques. And we have to change from the concepts of drilling and filling. Rather, we have to focus on re-engineering the tooth. So these have to be viewed on a bigger perspective. The treatments have to be, treatments are no longer as simple as we usually consider them. Gone are the days of just drilling and filling. So this webinar was focused on giving an insight into the newer developments which has happened in the industry. Now you have understood how restorative dentistry has changed over the years. Things which we considered as poor prognosis in the olden days, now it is like they are no longer that way. Even a root stump can be very well restored or rehabilitated. So the purpose of this course is to give you all an insight into the modern happenings in dentistry. So this program, as the heading goes, as the title goes, it's an introduction into these concepts. And it becomes impossible to teach you the techniques of doing all these types of dentistry in a 1 hour or a 1.5 hour webinar. It requires a dedicated training. These things cannot be done with just a webinar. I have to show you the technique. I have to come to you. I have to guide you, make you do the things properly. Only then you would be enabled with the proper skill levels, knowledge, and understanding to manage the case. Fine. So if at all you are interested in practicing this type of dentistry, you can join our workshops. We would give you a detailed idea of how to proceed with such type of tests. So this video is just to show you how the preparations have changed. You can see a decayed tooth. So the first thing in the management of a decayed tooth is to go ahead with rubber dam isolation. So here you can see the rubber dam isolation with the deep margin acquisition done with Teflon. Then we have to use a caries detector dye. The next procedure is to convert the tooth into an anti-fragile design. So the biggest problem with traditional dentistry was when we were preparing a tooth, we were reducing the strength of the tooth. Now, in modern restorative techniques, the first thing that we do in restoration is to convert the tooth to an anti-fragile design. And this is what you are going to see in the video. So this is where we talk about developing your skills. You can see that I am working on top of the Teflon, and I make sure that the Teflon never gets entangled on my burr. So this is the level of fineness which has to go into our routine working mode. So our hands have to be very gentle. It has to be very steady, and we have to continuously observe what is happening. So most of the time, what happens with clinicians is when you're working on the tooth, you lose your focus and you don't tend to understand what is happening on the tooth when you're working. So every point you have to focus inside the preparation, you have to see what is happening. So I'll apply the caries detector dye once again. So we are removing the fragile enamel, which is present around the lesion. So this is how we have converted the tooth into an anti-fragile design. Now you would never see any unsupported enamel. Fine, this is a very sturdy structure, and on top of this, we would be going ahead with the restorations. And now there are certain criteria which would help us to evaluate the structural status of a tooth. So we call it evaluating and treating the horizontal and vertical structural compromises. So when you see a tooth, for example, see this picture. So there are certain criteria which would help you to evaluate the horizontal and vertical structural integrity of the tooth. These are 4 factors. Cusp, which is thinner than 3 millimeter, fractures on the peripheral rim, isthmus wider than 4 millimeter, boxes deeper than 4 millimeter. Isthmus wider than 2 millimeter and boxes deeper than 4 millimeters. Let me repeat that. Cusp thinner than 3 millimeter, fractures of the peripheral rim, isthmus wider than 2 millimeter, boxes deeper than 4 millimeter. When you see these things on your tooth, you have to always consider that as a tooth which is weak structurally. Fine. Now the biggest problem is, I'll show you another case. You can see all these things. You can see a wide isthmus. The isthmus is wider than 2 millimeter here. You can see cusp, which is thinner than 3 millimeters. You can see fractures of the peripheral rim. And when you remove the silver amalgam, you would expect a box which is deeper than 4 millimeters. Now let me show you how we treated this tooth. So this is how we converted the tooth into an anti-fragile design. You would not see any unsupported cusp now. There is no fractures. All the fractured elements are removed from the tooth. There is no box type preparation. Fine. So this is how we altered the tooth into an anti-fragile design. This is the first step in restorative dentistry. Another thing which we have to always do in our restorations is to immediate dentin seal. Then we deal with fiber placements. And then finally, we deal with the enamel replacement. The enamel is replaced with direct composites, indirect porcelain, semi-direct or semi. And finally, after the restoration, we have to do the occlusal adjustments. So here's something which I do routinely is something called the 3-paper technique, wherein we make sure that the forces are verticalized on the posterior dentition. So let's see this case. So here the patient was routinely complaining of dislodged fillings. The fillings were never staying. So every 6 months, one or the other filling was fracturing off. So now let's evaluate the occlusion here. You can see the maximum intercuspation position and see the excursion. So the posteriors has to disocclude, but you can see that the posteriors are in contact, which is called the group function. So group function causes lateral stresses. And it is absolutely something which should not happen in a tooth which is restored with porcelain or composite. They dislodge. So here it is like we are working on the palatal inclined planes. So we just gave a palatal veneer on the crown so as to deflect the mandible more and relieve the group function. Now you can see how the group function is relieved. In excursion, there is disocclusion of the posteriors. And then we go ahead restoring the posteriors. So that is how things have changed. So everything depends on the occlusion. If the occlusion is not right, none of your restorations are going to stay. So this is all what I had to discuss today in this short session. And these are my fabulous mentors. You can see me with Dr. David Clark, the person who introduced the BioClear technique, and my mentor, Dr. David Lehman. He was my mentor for my biomimetic mastership. And then you can see the legend of Veneers, Dr. Galip Gruwel.
Hello.
So these are our forthcoming workshops. So we have workshops for direct composite restorations, for indirect restorations, and we are now introducing a 1-year mastership program for biomimetics, wherein we would be having monthly one session, one module every month. This would last for 10 months. Fine. You all would be doing real patient cases, all the clinical situations for deep margin acquisition, elevation, direct composite restoration, indirect, semi-direct, everything would be given. Fine. And there would be case discussions. And basically the participants have to do all sorts of cases. Fine. And finally, in 10 months, you complete the module. That is the biomimetic module, which is coming up. So now we'll go ahead with clarifying your doubts. You can ask me if at all anything you need to ask me, you can ask me now.
Good evening, sir.
Good evening.
Sir, on the first case, you have said there is an exposure of pulp on the mesial side and the distal side also.
Yeah.
On exposure of pulp without placing MTA or anything, can we place bonding agent, sir?
Yeah, that is what. It's like anytime you have exposed the pulp, that is a situation wherein you can land up in a failure. No matter you use MTA, whatever. What matters is how aseptically you are managing the case. So the criteria there is whenever you expect the pulp to be exposed, or in all deep caries cases, you have to start with rubber dam isolation. Once that is done, rest of the things would happen.
Okay, sir. Thank you.
Most welcome.
Sir, regarding caries detection dye, how long you have to keep in order to can you just wash it off immediately or should we wait for some time?
5 seconds.
Thank you, sir.
Sir, which bond do you use regularly?
See, I would always prefer using the Clearfill SC, Clearfill SC Protect, OptiBond FL. These are the 3 bonding agents which I routinely use.
Hello, good
In com-
evening, sir. Hello.
Good evening.
Hello.
Good evening. Good evening.
Yes, I'm also from AB Shetty.
Yeah, great.
2003 batch.
Yeah, 2000?
2000, I'm in 1997 batch. 2003 pass out.
1997. So we would have met. I was in 1999 batch.
Yeah, I think I remember your name, but I don't think I've spoken much with
Yeah.
you, I think.
Tell me.
Okay. So very good to know that our classmates are doing such great work.
Yeah. I remember seeing you. Yes. You
Really?
are.
Really?
Yeah. Yeah,
Okay.
great seeing you. Great seeing you.
Yeah. So I'm practicing in Bombay, Renuka Shetty. Okay.
Which place in
So
Bombay?
Bhandup West, near
Okay.
Thana.
I did my PG in DY.
Acha, DY Patil, Mumbai. Okay. Okay, so it's very great work you have done, Vince. I have no words
Thank
to
you.
express.
Thank
Like,
you.
excellent. Especially, how did you manage that pulp exposure was there, no? That also you didn't do root canal. I'm really surprised. What
No.
materials you have
These are
used?
things, see, that is what I said. See, one thing is like we have to understand our materials.
Okay.
So when you are using the Clearfill SE bond, there is something called the formation of superdentine,
Okay.
which is going to protect the pulp from acidic as well as alkaline attack.
Okay.
So these are the only gold standard bonding agents which is capable of forming something called the superdentine.
Okay.
Fine. That is the base of the hybrid layer is converted into an acid-base resistant layer. That is called as the superdentine.
Okay.
So you have to resort to those bonding agents, which will never happen with the universal bonding agents, which you are using now.
Yeah. I'm using that only. Old school. I just did my BDS.
And this
So
is the oldest school.
yeah,
So these are the bonding agents which is available from the 80s, mid 80s.
yeah, maybe. Yeah.
I am talking about the sixth generation bonding agents,
Mhm.
not the present universal bonding agents.
Okay.
Fine.
Yeah, yeah. So I would love to know more about those things also. Means what materials to be used. So that we can prevent root canal and and even the filling materials which you said don't no need to put the crown. So that also is very new to me. Crown
And
like without crown can you
crown is the
do?
biggest engineering mistake which we do on a root canal treated tooth. You remove the
Okay,
pericervical dentin.
right.
The ability of the tooth to withstand vertical loading is based on how much pericervical dentin you are preserving.
Okay.
So on a badly mutilated tooth, when you go for again removing the pericervical area, it is never going to stay. And you would
But
have
what
seen that in your
about
case. You would have seen
yeah,
the, yeah.
sorry to interrupt you, but what about the microorganisms like microbacteria that goes through the tooth structure and the filling? You say like that, no? There are micro.
See,
How do
I told
you
you that we have to
manage
do
that?
air abrasion. See, you have to always use a disclosing agent, disclose the plaque biofilms, and remove them with air abrasion.
Hmm.
Only then you should be going ahead with your composite restoration.
Okay.
Fine. And if you don't do all these things, it is going to leak again.
Yeah.
So what we are struggling is to get the interfacial gaps below to submicron level so that leakage will not happen. So normally in all conventional restorations, you have an interfacial gaps of 5 to
Yeah.
15 microns, which has to be less than 1 micron now.
Okay.
Fine.
But considering the food materials which people are consuming, no, means they're continuously eating food and all those
So
different.
when you don't have a leakage,
Okay.
so approximately I would explain it in this way. The size of a bacterial
Maybe,
cell would be
yeah, like
1
it is new to me, so maybe I will take time to understand your technique. Means
These things
crown.
we all take a lot of time to understand. The biggest issue is these things are never taught in dental schools.
Yeah,
And we don't have the habit of referring to the literature.
yeah. Okay, very good to know you, sir. Very
Thank you.
happy with your work also. Very mind-blowing work. I must really confess. I mean, it was really great
You would
looking at
see
all these
even more
things.
beautiful work. You can just see on my Instagram page. You can
Okay,
just see, I mean, you can just go to Outlook Dentistry.
okay. And I'll
I will,
connect with you for the materials also. Like what are the gold standard materials which you're using, if you don't
yeah, that
mind.
is what I said. The one thing which we would be using is the Clearfill SC bond, the
Okay,
OptiBond FL.
okay,
These are the gold standard bonding agents.
sure.
You can use Clearfill SC Protect, or the OptiBond FL.
Okay,
Fine. And if you want to follow my cases, you can follow me on Instagram. The QR code is here. You can scan
okay,
that.
sure. Yeah, okay. Just take a photo, screenshot. Just a
Okay.
minute. Yeah, yeah, sure.
Great meeting you, and
Okay,
keep
sir.
in touch.
Yeah, yeah, sure. Very nice meeting you. Bye.
Sir, good afternoon. Good evening, sir.
Left,
Hello.
left. Tell me,
Sir, you were covering the black triangles, no?
yeah.
How used to arrest the bleeding that time?
How would it bleed when you manage the black triangles? You're
No,
squeezing the papilla, right?
you were pushing the black triangle matrix into the sulcus, right?
There are very specialized matrices called the black triangle closure matrices, which would just compress the papilla. They'll not cause any bleeding.
Okay, okay. And you used to place rubber dam during the time of.
100%. You have seen all the cases. You can see the rubber dam being placed everywhere.
Okay, sir. Okay. Thank you, sir.
Sir, in BioClear technique, sir, use bulk fill composite or sir, normal composite?
Normal composite, which is heated.
Sir, which brand composite do you use?
You can use anything. I am not a brand specific person. I use something which is working for me. So my composites is like I use 3M, I use GC. I'm a speaker for GC also. I use GC, I use 3M, I use Curare. Everything is there. Even the dense ply ones also.
Sir,
Hello,
in
sir. Good
lithium
evening.
disilicate crown, we have to first etch with hydrofluoric acid 9% for 20 seconds. Then we have to acid etch for with phosphoric acid for 20 to 30 seconds. Was then, sir, we place in the ultrasonic bath, or sir, this step is obsolete
If
or
you're
still
using,
can?
that's all. I mean, it's like the best is if you keep it in an ultrasonic bath. Otherwise, you can use phosphoric acid.
Okay, don't both of are not the done.
You don't
If
require
we
both of them. It's like the best way is keep it in an ultrasonic bath for 5 minutes.
and sir,
So,
ultrasonic bath, which liquid is there
Alcohol.
inside the ultrasonic bath?
With alcohol. Alcohol.
hello.
Yeah.
So, if you're doing the layering, so can I put the separately put the bonding agent in every layer, or
Why you have to put bonding agent in every layer?
I'm just asking. So some dentists will doing the different thing.
No, not at all.
Actually, I'm calling from UK. I'm a dental therapist here, so I have a doubt.
Yeah, composite bonds, one layer of composite bonds to the next layer of composite because of the oxygen inhibited layer on top of that. So you don't have to
Mhm.
apply bonding agent between two layers of composite.
Okay, okay. Thank you, sir.
Hello, sir. Good evening.
Good evening.
Sir, can you tell me? You told a case. You were mentioning a case that there was a restoration which was being dislodged frequently, and it was in group function.
Hmm.
So you changed the group function to canine guided occlusion. Can you tell me how did you do that?
By altering the palatal inclined planes.
How did you do that, sir?
That is what see these are the things which it is like, see, there are cases where there are many cases wherein I have to deprogram, I have to do a faceport transfer, I have to articulate, and then I have to plan my palatal veneer. And there are, in some cases, we would be able to do this freehand also. So see, things are very easily said, but when it comes to the clinical management, things are literally difficult.
Okay, sir. Thank
So
you.
in most of the cases, you have to deprogram, you have to do a faceport, you have to take the centric, you have to do a faceport transfer, you have to mount, and then you have to plan your restoration.
Okay, sir. Thank you. Thank you very much.
Sir, is Opti1 FL available in India, sir?
No.
And sir, if we apply the primer, after that we have to dry the primer. Then we apply the bonding agent, sir. Then we also dry and light cure. And sir, after that we can directly use the GC Everex flow, or sir, normal composite after that.
See, those are things which require a lot of understanding. Different bonding agents have different protocols. Different manufacturers have different protocols. And it depends on which bonding agent you're using. The way you work with OptiBond FL is totally different from the way you work on Clearfill SC Protect. And that technique is different from how you work on Clearfill SC. So that is why I always say, always you attend a good program and then learn the things. Because otherwise, just hearing things and then trying it out on patients would not be all the fine every time.
Hello.
Yeah.
Good evening, sir.
Good evening.
Myself, Dr. Vinayak. I'm doing my PG in consonant
Great. Yeah.
department.
Tell me.
My
Yeah.
basic question was that at the time of POR, we should use that snow flow technique. It is advantageable, or we should go for regular bulk fill composite.
See, whenever doing post endodontic restoration, that is what you were asking, no?
Yes.
Fine. So post obturation restoration. See, composites can never be bulk filled unless you injection mold them.
Yes.
Fine. So if at all you're
Yes.
planning to injection mold your post-obturation restoration, you can go ahead and use the bulk fills. If at all you are not using injection molding, then you have to go with the horizontal layering technique.
Okay. And sir, my second question was, I am not able to do that occlusal anatomy perfectly. So can you guide me from where I can be a little bit more good in that zone?
Best way to practice occlusal anatomy, I would tell you the way I do things. Fine. So I don't know whether this is going to work with you. So
Okay.
I used to do soap carving.
Oh, okay.
So that is how I practiced occlusal anatomy.
Acha.
See, there is no easy techniques for us. We have to sit and practice things.
Okay.
Fine. That is how I learned occlusal anatomy, because when it comes to occlusal anatomy, the posteriors are very, very, very difficult. The first molar has a different anatomy, the second has a different anatomy, the first premolar has a different anatomy,
Yes.
the second has a different anatomy, which you have to practice.
Upper tooth have already very
That is what you have to
structural.
literally practice them so much that it should come freehand to you.
Okay.
Fine.
And sir, it is a little bit off-centered question, but I was thinking, in our regular clinical practice, it is important to do that occlusal anatomy, because most of the time after the POR, we are going to get an crown. So
I
the
don't get it. I don't do a crown. So it is important to me.
okay. And what you said, I have recently joined your webinar 10-15 minutes ago. I heard that most of the your RCTs have उनको most of the time crown होता ही नहीं है,
होता
but
ही नहीं, कभी होता ही नहीं.
हाँ, बट मैंने जितने भी आर्टिकल्स अभी जितने पढ़े हैं उनमें तो देखता है, मतलब हमने देखा है कि जब
That is one big thing that is happening nowadays. It is like we are overloaded with information. So the biggest problem now is now what happens is in choosing the articles which we are reading.
okay.
So again, as it goes with any other thing, even with the articles, things can be manipulated in many ways. So I mean, see, something which is very important is selecting the article which you're reading.
अच्छा, so और वो कैसे कर सकते हैं, मतलब
That is what. See, I told you, no, you have to sit and download things, read them properly, understand them, try it out. Then you will understand which is going to work for you.
okay. Okay, sir. Thank you.
Thank you.
Good evening, sir.
Good evening.
Sir, I'm a dental student. I just joined your webinar half an hour back. Thank you so much for the information that you've shared on this platform. Um, I had this question where you mentioned that after the root canal treatment, you don't prefer giving crowns to the patient because there's a weak pericervical dentine that's been present. So, is it a thumb rule that for all the root canal treated tooth, we have to do a composite restoration?
I didn't understand.
Like you mentioned to avoid crowns and do onlays and onlays. So is it a thumb rule that for all the RCT treated teeth we should
No,
do
no,
that?
no, I'll tell you one thing. It's like whenever you do an axis opening itself, things have to change. The axis opening when you do an axis opening, first thing before doing the axis opening, you have to convert the tooth to an anti-fragile design.
Okay, sir.
So it is never about just filling the composite inside. The dentin has to be replaced with composites which has similar modulus of elasticity of the dentin. You have to recreate the dentino-enamel junction by placing the ribbon fibers, and then you have to replace the enamel with a suitable material. So it is that difficult engineering. So when you're avoiding the crowns, don't think things are easy. Things are going to be 10 times more difficult.
Understood, sir. Thank you so much.
So I hope,
Sir,
yeah, tell me.
sir, in which case we are using rebound fibers in a badly destructed tooth?
In every case.
Every case we are using rebound fibers?
Every case.
Okay, thank you, sir.
Hello, sir.
Yeah.
Sir, which hemostatic agent do you use for, especially for retraction cord? Uh, is it aluminum chloride or ferric sulfate you deep in
Anytime
it to?
you're working with bonding, I mean, you have to use an aluminum chloride based.
Okay.
And if at all you're retracting for a preparation purpose, just like imagine you have to do a substantial veneer preparation.
Okay.
It does not matter you retract with, ferric chloride also. You're not going to do any bonding.
Okay. Okay, sir.
Fine. That's a rule.
Thank you.
Good evening, sir.
Evening.
Sir, I'm Ravi Sachdev from Gujarat state. Sir, first of all, you are doing a so great job that I really appreciate your work. So I have a question that I also don't give crown to many patients just like you. But I have found that in some maxillary cases and in mandibular molar cases also, in maxillary cases where I do the root canal treatment, which are the class 2 root canals, and I do the class 2 restorations also. But after 2 or 3 years, patient come back with palatal cusp fracture, and we
Yes,
have to. So if
exactly.
I'm doing
So
anything wrong
I
or
tell you, I'll
what?
tell you, I'll tell you. We were talking about evaluating and treating the horizontal and vertical structural compromises. So I
Yes,
said
sir.
that any box which is deeper than 4 millimeter is an issue.
Okay.
So that is what I said. Avoiding a crown is not a big thing. When you're avoiding a crown, your restoration, the engineering of your restoration totally changes. So right from your axis opening, you have to make deliberate attempts to incorporate that changes.
Okay.
Fine.
And sir, if we want to join the workshop, where is the location, sir? I'm here from
Yeah.
Gujarat.
See,
Uh,
it's like we have participants coming from all part of the country. So I mean the details, the contact number, everything is given on that slide now. Fine, you can contact us. And I would always say, see, this workshop is to make you aware of the recent advancements which has happened. And I am totally against, it's like hearing something and then the next day trying to practice it in on patient. You would land up in making errors. Fine. I would prefer you, I'm not telling you to attend my program. I would tell you to attend a good program, learn the things properly, and then focus on working on your patients. That is how we we really improve ourselves.
yes, definitely, sir. Uh, sir, just like me, as I really appreciate work and I really appreciate to polish our knowledge. So many of my colleagues and many of my college friends and other doctors are also interested, but due to some schedule issues and they are not able to leave the city. So, sir, if many of the participants, for example, 200 something around, are agree to join your lecture, so I don't know. This is silly question. So, sir, are you comfortable
But
to
that is
come
how,
to that set?
see that, I mean, let me keep things very simple. It is like, see, uh, I travel throughout. It's like now at present I am here in Colombo to, I mean, today I was having a session, a pre-conference session on posterior restorations. Tomorrow I have a keynote lecture, and the next day I have to be in Kochi. I have to manage my cases. So the
Yeah.
schedule is very busy. Fine. So the thing is, it is like once in a while, see, I guess in July we have a program in Jamnagar.
Okay.
Uh, so I mean that's a biomimetic workshop. So you can contact me. I'll give you the details of that.
Okay, sure, sir.
So fine, or you can follow me on Instagram
हेलो
wherein.
नमस्ते सर
Pardon?
कोई नहीं सर आप उनका जवाब दीजिए फिर मैं अपना क्वेश्चन रखती हूँ हेलो नमस्ते सर
Namaste. बोलिए आप.
सर जैसे आप कह रहे थे कि बॉक्स की जो डेप्थ है वो 4 mm से अगर ज्यादा होती तो सारा ट्रीटमेंट प्लान चेंज हो जाता है बट सर मैक्सिमम टाइम 4 mm से डेप्थ ज्यादा ही मिलती है सर ऐसा
हाँ
बहुत
वही.
कम होता है कि डेप्थ जो है वो उससे
Never, it
हमें
is
कम
never
मिले
below 4 millimeter. So that is why you have to use ribbon fibers. There is a technique called ribbon basketing.
ओके सर, तो मतलब यू मीन टू से कि हमें रीबॉन्ड को परचेज कर लेना चाहिए अपनी उसमें एलिमेंटर में से जोड़ लेना चाहिए कि हर टाइम हमें रीबॉन्ड देना है। और सर
हाँ
रीबॉन्ड से पहले आप जो बता रहे थे, तो सर वो उससे पहले जो फ्लोएबल लगाते हैं वो हाईली फिल फ्लोएबल होना चाहिए बॉन्ड के
see,
बाद में।
to be flowable, I mean, whatever you're using, it has to have the same
यस।
modulus of elasticity as that of the dentin. It's not whether it is highly
हम्म।
filled or it is, I mean, it has to have the same properties of that of the dentin.
सर एसडीआर ठीक है?
SDR ठीक है. You can use SDR, you can use aesthetic flow from Curare, you can use
ओके
Everex Global from GC.
ओके सर, ओके। सर अगर जैसे अभी रिबॉन्ड मैंने कोशिश भी करा था परचेज करने का, बट सर ऑनलाइन भी सर अवेलेबल मुझे जल्दी से हो नहीं पा रहा। मैंने सर जीसी का भी ट्राई किया था सर, एवरेक्स,
GC,
नो नॉट एवरेक्स, जीसी
GC,
का सर है ना सर, क्या नाम है उसका, डीएनसी, बीएनसी, क्या नाम है सर?
GC का some net fibers. It is not the, I mean, ultra high molecular weight polyethylene.
हम्म। तो सर अवेलेबल सर हो नहीं पा रहा सर,
नहीं,
कहाँ
नहीं,
क्या
you are
आप
not supposed
रिकमेंडेशन
to.
करते हैं?
You are not supposed to use the Everstick fibers from GC. I
ओके,
mean, you
यस
cannot,
यस, एवरस्टिक, यस यस यस।
you cannot substitute Everstick with Rebond.
ओके ओके
So you are not
ओके सर।
strengthening a restoration by doing a rebond. You are recreating the dentino-enamel junction. You are creating a
ओके
composite which can absorb the forces.
ओके सर, ओके। तो हमें पहले पहले हमें डेंटिन लेवल अच्छे से बनाने के बाद में देन वी हैव टू प्रोसीड विद, कि जब हमें डेंटिन लेवल जंक्शन बनाना है तब हमें रिबॉन्ड देना है।
Hey, that is what I
ओके
said. See, that is what I said.
ओके
Mimetics is a very
ओके सर।
complex thing. That is what I mean. I said, planning on a 1 year program.
ओके
Subject is so
ओके
vast.
सर,
The subject is
ओके
so
सर,
vast, and I'm not doing justice if I
यस
just
यस, राइट सर, राइट सर।
if I explain it in 2 words. You would end up doing wrong things.
ट्रू।
Fine. So subject is too vast. We have to, I mean, we are planning on a 1 year biomimetic mastership program.
ओके सर, ओके सर,
Fine. Yeah.
Hello,
थैंक यू
sir.
वेरी मच
Good
सर।
evening.
Pardon?
Hello, sir.
Yeah.
So I
Tell me.
have a question. So in your cases, how would you manage composite shrinkage and all?
No, that is what. See, there are many techniques to avoid the composite shrinkage. One thing is you have to manage the composite in 1 millimeter horizontal layers so that it shrinks towards the substrate.
So, but eventually, over a period of time, the composite will shrink, right?
No,
It won't shrink at all.
it is polymerization shrinkage.
Yeah, but that would lead to leakage later on.
See, if at all it shrinks rapidly during the time of polymerization, then you have spaces formed on the sides.
Mm-hmm.
So when you avoid that by the right technique of form, and then the technique is called stress reduced direct composite technique.
Okay.
If you follow those techniques, you would find that after 10 years also your composite stays the same.
Okay. Okay.
Fine. See, first thing is you have to modify your tooth preparation. The biggest mistake we did is we were filling composite into a preparation which was meant to receive silver amalgam.
Yes.
So composite के preparations अलग है.
Hmm.
Fine.
True.
So you have to learn the composite preparations. You have to reduce the C factor by reconfiguring your cavities.
Mm-hmm.
You have to do immediate dentin sealing. You have to decouple. A lot of things which
Okay.
goes into when you have to do a successful composite restoration.
Okay. Okay, sir. Thank you so much.
Thank you.
Sir, good evening, sir.
Good evening.
Sir, I have a doubt. Like, in case where we can use post, is there post and core? In that case, also we can use this ribbon.
Yeah, you can do a ribbon post.
Ribbon post means like
You
both
prepare the post
combination.
space and you can prepare the post space and you can pack the ribbon into the post space.
Okay, okay. Then followed by the composite buildup.
Yes.
Okay, okay. Okay, sir. Thank you.
हेलो।
Yes.
हाँ सर, मैंने भी अभी रिबॉन्ड टेक्निक हाल फिलहाल में यूज की थी। बट माय बेसिक क्वेश्चन, जो भी अपन रिबॉन्ड मटेरियल प्लेस करते हैं, नॉट रिबॉन्ड, जो भी अपन मटेरियल प्लेस करते हैं, वो सिर्फ सरकमफरेंशियली प्लेस होना चाहिए या एट द बेस ऑफ कैविटी भी होना चाहिए?
Well, I mean, you have two techniques. You have ribbon wallpapering and you have
Yes.
ribbon basketing.
Okay, I think I have done a wallpapering technique.
You
So,
can do a ribbon basketing also.
okay. And talking about sir, we have various technique to strengthen our PR to avoid crowns.
See,
Then we have
let me tell you one thing. You are not strengthening the tooth by placing ribbon.
okay.
You are making it absorptive to forces. Well, tooth can absorb more forces by placing a ribbon.
Yes,
You don't
exactly.
strengthen the tooth by placing ribbon. We don't require very strong teeth. When you have a very strong tooth, it would spoil the TMG.
यस 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 यस। तो सर, अगर अपन ने दूसरी टेक्निक अगर सोचे तो वॉलपेपरिंग हो गई, बास्केट हो गई, उसके सिवाय और कुछ है मतलब जो अपन यूज कर सकते हैं?
मतलब you
अ,
you can use a rebound over your leftover outer carious dentin.
yes.
Fine. You can reduce the polymerization shrinkage stresses by using it as a wallpaper.
Okay. Yes.
You can introduce force absorption by doing a rebond.
Hmm.
Even rebond retained, bridges can be done in the anteriors.
ओके।
Fine.
और सर मेरे को जो फील हुआ रिबॉन्ड टेक्निक जो मैंने यूज की थी, उसका प्रॉब्लम जब मैं क्राउन कटिंग कर रहा था उस टूथ की, तो जो डिस्टली मैंने प्लेस किया था, डिस्टल वॉल थी ही नहीं उस पेशेंट में। तो मैंने डिस्टल वॉल बिल्डअप की कंपोजिट से और उसके ऊपर रिबॉन्ड मटेरियल ऐड किया।
And
लेकिन
you
जब मैं
expose the rebond when you are preparing the tooth for the crown.
नो, जो हमारे स्टाफ था, मैं उस उन्होंने मेरे को वार्न किया था, बट जब तक उन्होंने मेरे को वार्न नहीं किया तब तक मेरे को पता ही नहीं था। तो मेरे को भी बाद में चला गया, और जब मैंने आर्टिकल्स देखे तो वो भी था कि ऑक्लूजली अपन ज्यादा रख नहीं सकते, और जब भी अपन क्राउन दे रहे तो मिनिमल प्रिपरेशन वाला ही क्राउन दीजिए, लाइक मेटल क्राउन।
सोचो आप crown दे रहे हैं. It's like your rebond has to be 2.5 millimeter inside the tooth. Otherwise, occlusal reduction में वो expose हो जाएगा.
वही वही एग्जैक्टली।
So everything is on planning. You have to plan the final outcome and accordingly you have to place.
ओके।
So what is the
और
point in placing if you're exposing it and grinding it when you're preparing the tooth? Purpose,
yes,
you lost the purpose, right?
हाँ
वही.
ओके। और सर मेरे को ये भी जानना था, आई हैवंट यूज्ड दैट सेंटियन बट आई रेड दैट
Yeah. Dr. Vinayak, your voice is breaking. I didn't hear you.
हेलो
सर आइनोड फाइबर्स यूज कर
ऑडिबल
सकते
नाउ?
हैं क्या?
Pardon? Hello?
हेलो
Hello? Yeah. No,
सर
Dr.
आइनोड
Vinayak
फाइबर्स
was
यूज
asking.
कर सकते हैं क्या?
No, Dr. Vinayak was asking me something. He left a what?
ये सर मैं यही पूछना चाहता था कि जो सेंटियन मटेरियल था, मैंने तो यूज नहीं किया, मैंने पढ़ा है उसके बारे में, तो आप कुछ आइडिया है आई शुड यूज इन माय
Those are
पीजी?
materials. So see, it's totally dependent on you whether you come in. You can go for GIC, you can use for Centurion, you can use anything.
ओके।
Fine.
एंड फॉर मिरेकल
But you will not be able to call them biomimetic restorations because they are not biomimetic materials.
यस यस यस।
Fine. You can use a silver amalgam also. When done properly, all these things work.
ओके ओके सर, थैंक यू।
Okay. Thank you, Dr.
सर आइनोड
Aman.
फाइबर्स यूज कर सकते हैं क्या? आइनोड
Yeah,
फाइबर्स
sure. Iron fibers you can use.
मतलब वो ऐसे अगर देखें सर, क्या बोल सर, दीज आर वेरी एक्सपेंसिव, लाइक इफ आई सी द रिबॉन्ड दे आर वेरी एक्सपेंसिव एंड आइनोड दे कम एट हाफ द प्राइस ऑफ रिबॉन्ड.
Not even half the price.
या लाइक आई गेस वन थर्ड प्राइस पे आएगा शायद.
Yeah. So I have used iron fibers as well, and I have never found anything going wrong in the last 5 years with iron.
Okay.
You don't have any literature which is claiming a long-term success rate with iron. The only thing is that the only problem is that clinically I've never found a problem with iron.
Okay, sir. Thank you.
Thank you. So I hope we'll wind up for the day. And once again, you can follow me on Instagram. You can scan my QR code, and you can the numbers are given here. If you're interested in our courses, you can always contact us. We have our monthly programs on direct composite restorations, endodontics, bonded porcelain restorations, that is veneers and overlays, as well as we have a mastership in biomimetic restorations. So if you guys are interested, you can contact us. And yep, that's all for the day. Good night.
Good night, doctor. Good night.
Good night. Good night.
Yeah. Actually, one more thing I want to tell you ki,
Ask me.
I mean, I've seen so many, all the cases going for implants and all, all these root stem and all extraction karke. So this is very new thing and very good thing, I think. I mean,
it's not at all. It's not at all a new thing. Fine, it's not at all a new thing. If you see Dr. Aleman and Dr. Pascal Mani, they were doing it from the late 70s or 80s.
yeah, but because of implant and all, no, like quick fix solution, I mean, these things are not being brought into.
I do implants also.
Yeah, but if
Fine,
okay.
but the thing is, it is like there are many situations. See, the way we were looking at restorations have totally changed. Those things we were taught as things with poor prognosis are no longer so. Materials have changed, science has developed. Now it is like all these things can be restored. And this is not something new for your information. If you just follow Dr. Aleman or Pascal Mani, they were doing the same things from 1980 onwards.
Okay.
Fine. So these are not at all new. The only problem is our curriculum was not focusing on all these things.
Right.
Fine.
Okay.
So
Good
thank
luck.
you.
Good evening. Yeah. Good to see
सर
you.
एक
Bye.
और क्वेरी थी
Yeah.
सर जिसमें ऑलरेडी सर क्राउन हुआ है उस केस में जब कई बार ऐसा होता है कि क्राउन हमें डिसलॉज होकर के मिला और वो ग्रॉसली डिकेड हो गया टूथ जैसा आपका अभी आपने देखा था रूट स्टम्प्स रह रहे हैं ऐसे सिचुएशन में क्या ऐसा होता है कि अगर ऑलरेडी क्राउन है उसके बाद में अदर देन क्राउन कोई ऑप्शन नहीं है या हम इस टेक्निक के साथ में जा सकते हैं जो आपने बताया है अभी
Yeah, sure, 100%.
ओके क्योंकि सिचुएशन तो वही आ गई ना कि रूट स्टम्प है
हाँ तो वो सिचुएशन में इट इज लाइक रूट स्टम्प ऐसे सिचुएशन में इफ यू आर अगेन गोइंग फॉर अ क्राउन प्रिपरेशन यू आर स्पॉइल्ड द पेरीसर्वाइकल डेंटिन राइट
यस सर
you can never think of a crown there. You go ahead with the dentin replacement and then you do the enamel replacement.
सर प्रोस्थोडोंटिस्ट जो मेरे पास अभी आ रहे हैं ना पहले एक्चुअली मैं यही फॉलो कर रही थी पिछले 2 to 3 इयर्स से मैंने क्राउन्स बिल्कुल बंद कर दिए थे और मैं पोस्ट ऑप कॉम्पोजिट रेस्टोरेशन ही दे रही थी और अभी तक बाय गॉड्स ग्रेस सारे ठीक भी रहे बट सर काफी कुछ चेंज हुआ है
let me tell you something. You cannot do a simple post-op obturation composite restoration and you can never think that things are done.
Okay.
Fine. It has a technique. It has a technique. You have to manage it properly. We are never doing a simple post-obturation composite restoration. We are replacing the dentin. We are replacing the dentin enamel junction, and then we are replacing the enamel. After that, we are equilibrating the occlusion. We are verticalizing the forces. If these things are done properly, then composite works.
सर मैक्सिमम आई एम ट्राइंग दोस थिंग्स 90% केसेस मेरे सक्सेसफुल भी हैं वो 10% केसेस कोई मतलब जैसे प्रोस्थोडोंटिस्ट आए ना तो उन्होंने जब मुझे बोला ये बात कि नहीं इस केस में हम इस तरह से जा सकते हैं ज्यादा बेटर रिजल्ट रहेगा तो मेरा माइंड थोड़ा सा चेंज हुआ लाइक ही सेड कि हाँ ऐसे ऐसे करके मतलब आपका मतलब मनी भी थोड़ा सा
it is all again personal perspective. See, I'll tell you one thing. I mean, my focus was always into restoration of badly mutilated, which is what I was doing from my post-graduation days. For the last 20 years, I did the same thing. And it is like I shifted to this type of dentistry by seeing my own failures with conventional dentistry.
Okay, sir. Okay.
All those cases wherein we have done crown lengthening, post-in course, crown, everything, it's like after 5 years you would see, or 10 years you would see, they'll end up in a catastrophic failure. So here the biggest advantage is the worst thing. If at all a failure happens also, it would be always a fracture of the restoration. The tooth is still intact for another restoration.
Right, sir. Right,
That is the
sir.
biggest advantage here. I'm not saying that this will not fail. In case of a failure, it will never be a catastrophic failure. Maximum, the restoration fails.
Yes, sir.
Nothing
Right, sir.
happens to it.
Thank you very much, sir.
Thank you. So, okay, once again, good night.
Good night, sir. Thank you.